Let us start with our next session. I invite on stage Mr. Mitesh Dave, who is the Chief of Operations and Business of Indira IVF Group. Welcome, sir. Next, I invite Dr. Sarjana Dutt, who is the Director, National of Reference Lab, Pathkind Diagnostics. Welcome, ma'am. Next, I invite Dr. Arunkumar Govindarajan, who is the Director and Radiologist at Aarthi Scans and Labs. Welcome, sir. I also invite Mr. Sumit Goel, who is the Managing Partner, Lead of Healthcare and Pharma at Praxis Global Alliance. Welcome, sir. To join us on this session virtually, we have Mr. Viswanathan NS, who is the Chief Financial Officer of MFine. Welcome. This panel discussion is on the topic of patient-centric transformation of Indian labs over the era and its future. Mr. Sumit Goel would be leading this panel for us. So over to you now. Thank you.
Hello. Yeah. Thank you and good morning, each one of you. It's a pleasure to be here and moderating this panel. So I'm Sumit. I'm a managing partner at Praxis and been a veteran of management consulting for almost 16 years now. So before that, I was with KPMG as a partner, leading the healthcare consulting practice and started with EY. So been fortunate enough to be in healthcare and seen the evolution of healthcare over the period of time. So if you talk about private healthcare today, I think most of the things which we see today is a phenomenon of last 20 years, where maybe say Fortis and Max coming up in early 2000s, then a lot of players like Medanta, a lot of labs evolving. So it's a 20 years which has actually defined what the private healthcare today is. And it has been undergoing a lot of transformation, a lot of interesting things which are happening. And we are fortunate enough to have a good, very senior panelists who represent the industry, our diagnostic industry. So, and I think we will be talking on one of the very important topics on how the diagnostic is evolving, especially considering the patient centricity and what are the kind of changes which are getting driven. So to start with, I will start with Dr. Sarjana Dutt and starting with, what is your take on patient centricity? Because I think it's very important to understand what we are talking about. And then, what are those expectations which are evolving? And accordingly, some of those operating model changes that you see, like how to address those expectations and what are the kind of changes that you're doing within your labs?
Thank you, Sumit, and a very good morning to all of you. And I'd like to thank VOH for inviting me here today. And thank you for that question, Sumit. So as you correctly mentioned, over the past couple of decades, and more so in the last 2 to 3 years, we've really seen a sea change in, what and how the expectations of the customers, the clients is evolving. And along with that, be it the hospitals, the healthcare segments, the digital platforms, or the laboratories themselves have had to have a relook at their own operating models in answer and to meet the client expectations. Having said that, I represent Pathkind Diagnostics, and we are a laboratory chain with over 76 labs across 23 states of India. And one of the USPs I would say about our organization is that we took as our business model the fact that we would go into one territory and go deep into it. What that really means is that we are catering to clients, customers, patients, doctors, not only in the metros, in the tier 1 cities, but also to tier 2, tier 3 cities. And really the customer expectations in both these segments are quite different. So when we look at tier 2, tier 3 cities, primarily what the patient, what the doctor expects is that you give them affordable solutions, affordable tests with quality, accurate reports, fast turnaround time. Primarily that. but also the fact that in those segments, there is lots more hunger for information. And apart from just giving out the reports, it falls onto us to also satisfy that need. So, which brings us to the fact that the laboratories, the hospitals working in those segments, they must also engage with the customers, be it the patients or the doctors, to provide information, to provide solution, to provide counseling as and when required. But that is again sort of like, a double-edged sword, so to say, and it's important that the laboratory chains, they should like, be very mindful of the boundaries, that while we are imparting that information about the results and the reports, we should not really overstep our boundaries. However, when we come to the metro cities themselves, the ask of the customers is very different. They want the convenience of home collections, they want the convenience of multiple options of making out the payments, but then at the same time, right from the sample collection itself, down to how and when the report is being generated, they want to be informed at every step of the way. So any lab today, if they want to make a mark, it is absolutely imperative that they have a very, very strong IT backbone, that they have a strong presence in the digital space, that they have solutions. And we do have quite a few labs which are stepping up to that ask. So we have, like, laboratories which already have digital apps, wherein not only do they provide the options of picking and choosing the tests themselves, but also help in choosing those correct tests, in providing test counseling, both pre and post. So there is lots of, like, changes which are ensuing, especially post-COVID. Everyone has, like, sort of woken up to the fact that not only is it a requirement, but it's really helping us evolve much faster.
Thank you, Doctor. Moving on to Mitesh, your business is in IVF, and as an IVF chain, I think you will also be a customer to the diagnostic chains, because a lot of your tests will be done by them. So it's sort of a B2B customer. And at the same time, your patients will also be getting a test done from them. So as a customer, as a B2B customer, and also sort of a person who's, as a chain, also an indirect customer for your patients. So what are your expectations from the labs, and how do you see those expectations getting handled with time?
Yeah, hello. First of all, thanks for inviting me here, Voice of Health, Dr. Naveen Nishal. Yeah, entire lovely audience out here, and to answer you, or to put forward my point of view towards the question as in B2B partners expectation from the lab. So let me begin with a little. When pandemic turned up, like, so it has actually shown world over the actual what exactly the mirror is all about in terms of the healthcare system. So when actually I figured out at that point of time, I was with pathology, one of the renowned pathology chain, right? So it turned out to be wherein, yes, there was a reach, but talking of effectiveness or efficiency was highly missing. One, going towards the getting into the volume game, or I should say commercial game, is the one piece. It's a part of a business. But at the end of the day, it is more towards the patient. And when I personally have observed, seen, and have experienced, while reports are coming once the patient is off the bed, right? So is this the kind of network we are really looking for? Not exactly. But on talking of the network, yes, we have that available network. And those already available network is kind of a B2B partner to the organized player. be it is a national or a regional or a local big player. So considering B2B partner as an volume-based or a revenue-based or as a number-based piece, instead considering that as one of the existing channel partner, taking hand on hand with the grooming today, exactly what Dr. Sarjana Datta has said, that yes, doing the digitization, getting into the reach, meeting out the expectations of the patients and all, but how deep it is going along with the B2B partner is very important, because still today, 92% of the entire spectrum in pathology is catered by the unorganized B2B market. And if that is the youth, I should say that that's the kind of 100% market catered by the B2B piece or the B2B players. So it's very important to groom them for a qualitative pathology. How to groom them? By bringing up the efficiency in their localized operations or the clinical operations, be it is a basic hemat or a biochemistry or the immunology testing, or to the super specialized testing, how to even draw the blood collection is equally important. So expectation from a B2B is very simple. Instead considering as one of the competitor into the local market, if it's the kind of turnout to be the channel partner for you, then it start bringing up the qualitative parameters in the system, which is like training them, training their staff around clinical and non-clinical, all kinds of protocols, be it is a collection, be it is a patient experience, be it is a processing, be it is a how to operate a machine. I even have experience, government has provided ventilator at many of the remote places, but staff was not aware how to operate it. That was really sad. So 75% of the overall healthcare industry is driven by pathological results, right? So you can imagine the impact, and 5% of the pathological revenue is in totality contribute to the 100% of the healthcare revenue. So if 75% of all the treatments are associated with the pathology, then it is our responsibility as a torchbearer, as an leaders in the society, that we should take along the B2B partner by the virtue of communication, awareness, by virtue of CMEs, RTMs, training of the staff, effective communication, automation. Lovely, it's an amazing word these days, world over, globally. But how far these B2B labs are automated even to do, they can't afford to have a 5 parts automated cell counter, right? They're working on basic ones, where the quality, quantity, and the throughput all are like substandard. What are we doing them to connect in our network, to bringing that quality and pouring it down to the last mile? So automation is the another tool to bring in the efficiency. CMEs, RTMs, joint CMEs, RTMs, their training programs. And last but not least, B2B partner, because talking of TAT or quality or the services, these are like by default stuff. Today, sample collection has to be on time. Yes, it has to be on time. There is no compromise to it. It has to be accurate. Yes, it has to be accurate. Right? I'm sending it to a recognized or renowned laboratory. But apart from that, so this is where a B2B partner expect more than the services. How are they engaged? How they are getting groomed to the next level to contribute to the society in the remotest place at any given point of time.
Thank you. Thank you so much. Now, I think that's a very important point, that if we have a B2B partners, how do we take them along? Sort of, it's not like an isolated, that sort of a customer and a vendor kind of relationship, but working together, because at least the patient should realize that, for them, it's a seamless kind of an experience that they're getting. And internally, there's a partnership which is actually helping them deliver a good kind of output results, which is important. So moving to Dr. Arunkumar, you represent radiology. And when we talk about some of those parameters of patient centricity, like convenience, and in pathology, convenience can be represented in terms of home collection, radiology is very different. Patient still has to go to the labs. So when we talk about patient centricity in radiology, so what does it stand for? What does it mean and how do you deliver that?
Thank you, Sumit, for the question. Thank you, Voice of the Healthcare, for giving me this opportunity. So pathology as a space is very well understood because a lot of listed players out there, a lot of articles out there, how to scale a pathology business, how to be patient-centric in pathology. But radiology is a little less understood than pathology. So just say 4 differences, like how radiology differs from pathology. So the ticket size, first one, the average ticket size in pathology is 600 to 700 bucks, whereas in radiology it can range from 7,000 to 21,000 for PET CTs. Second is there is a very less long-term or chronic care. So routine patients visiting is very less in radiology. Radiology is usually on a need to take basis. If you have an appendicitis and severe abdomen pain, you come for CT abdomens. You don't come for CT abdomen other than that. Third difference I see with radiology is the one you mentioned, that patient has to come to the diagnostic center to have a CT or MRI or ultrasound scan in presence of a radiologist. So to correctly say, as Dr. Sarjana told, affordability, quality reports, and TAT are the main things. And the radiology specific stuff of patient centricity goes towards reduced scanning time. So the patient has to spend around 20 to 25 minutes within a MRI console and at least 5 to 10 minutes within a CT console. And claustrophobic patients find it especially hard to be that. So we partner with the OEMs to design sequences, MRI sequences and CT protocols with iterative reconstructions, parallel imaging to reduce the scanning time from what used to be like when I started radiology as a radiologist. It used to be 45 to 60 minutes for a MRI abdomen scan. At present, because of the new scanners and new parallel imaging techniques, it has come down to close to 20 to 25 minutes, which is a great thing in for patient centricity. So just before COVID, we did a small survey with our patients as well as referring physicians. And one more difference between pathology and radiology is a radiologist is considered a doctor's doctor. So when a doctor who's treating the patient has a doubt, he refers them to a radiologist. So we consider 2 customers. One is a patient and second one is a doctor. That is one more customer of us. So we got in feedback from both of them. First one was affordability, second one was quality of reporting, and third one was TAT. But patients gave us 2 radiology specific stuff. One was a decreased scan time, which I said how to decrease. And second one was how they asked us, you are making us wait for 2 to 3 hours in the center without doing nothing. Basically, before scan, we need to build them. We need to give them scan instructions, counsel them. We need to tell them that MRI will be super claustrophobic, super acoustic difficulties will be there. Everything we have to tell them. And there is usually an emergency in a CT or MRI scan, and then the patient has to wait for some more time. And for ultrasounds, they need to fill their urinary bladders to get a good acoustic window for ultrasound examination. Everything is difficult, and we said to the patients, we cannot do much about it. We can increase CT and MRI patients. They wanted the entire scan center to be air conditioned, whereas ultrasound patients, because they're filling their bladders fully, they said switch off all the ACs. So we have same waiting areas for both the patients. And with a full bladder, with the AC switched on, it's very, very difficult. So we're still figuring it out, you can tell. And yeah. And safety is one more patient-centric thing, which is more important in radiology. So MRI, magnet safety, you cannot let a patient with stretcher or steel items in their body to go in. You need to scan them fully. CT contrast safety, the patient can literally die in the console if he has an anaphylactic reaction. So we need to always have a radiologist or a MD physician in duty. And radiation safety, when it comes to CT scanners, we need to provide as much radiation to the patient to get a good result. And fire safety is one more important thing. We run all these centers with 160 kVA, 200 kVA, transformers in our centers with high amount. If a CT angiogram and MRI of musculoskeletal imaging is taking place at the same time, we can reach peak loads of close to 170 kVA. The transformers can get overheated. So we cannot avoid this stuff. So we teach our all the staffs and doctors how to mitigate any incidents that happen. Unfortunately, so far nothing has happened, but we need to be always prepared, and safety is one more aspect which we concentrate on.
Thank you, doctor. I think one thing is very clear. It's not very easy to balance the expectation of different patients, like switch on the AC, switch off the AC, and there's always like different dimensions which come into play. A question to Vish. So you are also a very renowned CFO, and there are a lot of initiatives which will be coming to you saying that for patient centricity we should do initiative A, B, and C, and each one of them could have a different impact. So when we look at patient centricity and from the impact of, do they really make business impact and business sense? So how do we evaluate what are the things that as a business that you should invest in, and what kind of initiatives really help the business to grow? Wish you are on mute, I guess.
Am I audible now?
Yeah.
I'm audible? Yeah, sorry. Thank you for having me. Unfortunately, I couldn't travel due to some commitments. Yeah, very interesting question, Sumit, and to all the panelists. I know most of them sitting on the panel. I know you, I know Dr. Arun. We interact most of the days on many of these issues. So, as a CFO in healthcare and especially in labs, I have figured out that the business economics is dependent upon how you build the unit first. The cost of setting up the process of setting up is the first thing, because you choose what kind of patients you want that point of time. You decide how to. A Taj hotel will decide what kind of consumers it wants, and that's how it's building its own lab system. So I think first thing is, from a patient centricity perspective, as a finance guy, is what kind of patients you want to cater to, because it depends on, are you wanting to cater to a government scheme patients versus cash paying patients, etc. Because there's a difference in expectation from the patient in terms of what is expected out of the center, and there's also unit economics which differ. So these conflicts of having an AC room, non-AC room, certain things are required clinically, which you need to have. People have discussed about that convenience, etc., which are not compromisable irrespective of where the patient is coming from. But the view is, yes, it's primarily grounds up when you're building your center, when you're building up your business itself, you need to know what you're going to invest in for and what the expectations you're going to set for the consumer. And that's where it all starts.
Thanks, Vish. Thank you so much. Moving back to Dr. Sarjana, one of the things that you mentioned is that when we're looking at patient centricity, how do we internally equip our labs? Because to give a good quality results, the lab should be operating and all the machines should be operating within the quality standards. But at the same time, to make them more efficient, there's also a focus on the automation. So how do we balance this automation and a need for supervision and quality standards so that this is balanced out and a good experience can be given to the customers?
So I'd first like to start with a small piece of statistics. In India, we have over 1 lakh laboratories, organized, unorganized sector both. And if you look at the number of qualified MD pathologists that one has, it would be close to about between 12 to 15,000. So that just goes to bring the harsh reality in focus that most of these labs are probably operating without a qualified MD pathologist. And that I would say as healthcare providers, be it the hospitals or be it the laboratories, it falls upon us what we choose to do. In what space do we operate and how do we go about it? So for instance, at Pathkind, what we've decided is that whether it's our lab in a tier 2 or a tier 3 city, each one of them would be manned by a full-time MD pathologist, because quality remains our focus, and that is something that we do not want to compromise on. Having said that, yes, I mean, in an ideal world, we would want each one of our labs to be completely well equipped with the best possible automation. But the ground reality is that at the end of the day, to make the business run, for it to grow, it has to be financially viable. And so one has to look at the balancing act. So yes, in the network labs, in the national reference lab, we try and bring in as much automation as possible. However, in the probably smaller labs, what ourselves and many other laboratories, the path that one chooses is to focus on quality with only limited automation. And how do we do that? Again, we have, in retrospect, we have the COVID pandemic to thank a lot for, because earlier it used to be primarily that you go physically to visit a site if you wanted to do an audit. But now that we know that even our premier accreditation body, NABL, is able to hold audits virtually through the web. So that is what we've started doing even for our own labs. So now the way we manage quality, of course, in-house you have qualified people to manage quality of your systems there, but we also do surprise virtual audits. We're also using the platforms to upgrade our people, as Mr. Mitesh, he pointed out a very, very important aspect, that it need not just be how technically well equipped you are at the National Reference Lab, or what is the level of education, qualification, experience of your people there, but it has to be down to your centers in the tier 2, tier 3 cities. So for most of the laboratory chains, really, frankly, the front face of us is the phlebotomist who is going for the sample collection. And he really represents just what the company is all about. So their own training, their own upskilling, including the soft skill, is again something which one can do very well using the virtual platforms, the automations, and by and large, the rest of it, yes. And now, because of the pandemic, the ask of the laboratories themselves has also increased. So when we look at our vendors, we are not only asking them to give us platforms which can process a number of samples. So it's not just how many more number of samples of one kind can be done at one point of time, but we want random access, we want reagents which are of dry chemistry, so that one can tackle the storage issue, the temperature, the logistics of getting your reagents out to the remotest of places. And I'm happy to say that, many of our vendors are really stepping up to the act, and there has been a plethora of new technologies that have come in. Then automation in terms of digital pathology, that has come up in a big way. So has telepathology. So both the doctors as well as the labs are now really open to reaching out to their clients, customers, both doctors as well as patients, through the telepathology network, be it providing more information about the tests, having RTMs, having CMEs through the digital media. So I would, from a lab perspective, put all that as, using the platforms, using automation, using the digital space in the best possible manner.
Thank you, Doctor. I think it's a very, very insightful thing, because if what we see is just, the collection centers, that is the, as a customer, as a patient, that is what we all know. But the dynamic that go behind that in terms of, the sample travel, the sample is traveling, within those temperature controls, it is not getting spoiled, the way it's getting processed. I think that's a good insightful thing, because so those are the things that really matter from the getting the correct result. And
just to sort of add to that, we all know that the greatest number of errors that happen in healthcare are at the pre-analytical stage, up to about 65 to 70%. And hence, the sample collection, how it is being collected, whether it is being collected in the correct sort of containers, the vacuitainers, what is the modality of collection, how the sample is being stored during its transit, is the temperature controlled conditions being monitored or not? So if a sample has to travel from, let's say a small, I mean, we have labs in small towns such as Gonda, Bahraich, Sultanpur, which many people might not have even heard of. And to ensure that samples travel from there to whatever is the nearest processing lab in the right sort of temperature conditions is again a very important aspect. So the logistics of it, again, one doesn't tend to discuss about it in in big forums. However, and very, very critical imperative aspect of healthcare and laboratory testing.
I totally endorse that because see, we have done some engagement just focusing on the travel of the samples so that samples are traveling within a temperature control, they are reaching on time so that the reporting can take place on time. And there are different like control tower kind of solutions people have implemented. So moving on to Mitesh, again to you. You were with the labs earlier and you have now with IVF and you've seen the industry evolving. So what are the most prominent initiative that you've seen, how the customer expectations have changed and some of the initiative that you have seen labs undertaking? So what is the change that has taken place over a couple of years?
So as I said, I worked prior in the laboratory chain, and now with the Indira IVF, which has got close to 110 hospital in all those small locations that you mentioned, including Sultanpur. Yeah, and so need for us and how unmet or the met expectation from a patient in the areas of pathology. So I'll start with both IVF as well as pathology. Need of a patient towards pathology or IVF or any healthcare sector in Mumbai be like absolutely you can say 180-degree if we'll go towards the interiors of UP or Bihar, or maybe the southern part. Southern part is altogether a different nation where apart from need, there is an awareness to a larger extent. So if I have to tell you what are the basic need in each category, like there are two categories, illness or wellness. In illness, the need is like when I'll get the report and I'll meet my physician to get treated. In wellness, my curiosity, my anxiety is so much that I need the report when I'll get the report to see that yes, I am fully fit. So in both the categories, certainly first is the TAT. Today, what patient wants, the moment one has given out the blood, after half an hour or 1 hour, will receive a call back that when I'll get my report. That's the kind of expectation.
One of them.
Yeah. Secondly, patients I have personally come across so many patients giving out blood to one chain, then to another, then to the third, checking out or comparing the reports themselves without understanding what kind of a platform one chain is using, be it is a Abbott or a Roche or Transition or whatever, where exactly the sample has processed, what are the reference ranges. But that's where again the chaos starts. Look, I got it tested in X, it is saying a Y report, it is in Z lab, it is saying A report. Here you are wrong or those are wrong, now prove me. Those are kind of unmet or unjustified expectations. But yes, what basic expectation is, it should be absolutely quality report. Third is, yes, accessibility for them, which is a basic report. Like, yes, it should be very, very accessible, be it is a lab at home collection or maybe the over the time lab, or maybe office collections has also started now, wherein the phlebotomists or the technicians are moving up to the office premises also, because most of the time in many metros, professionals are in office from the 8 a.m. into the morning to the 8 p.m. in the night. So they barely get in time to get their blood collected at home. So they might usually calling it at the office also. And fourth, so accessibility, and fourth is the affordability, wherein patients today, even in the smallest, deepest town or the remotest town, they are very well aware of it versus what are the rates for a X test in the ABC laboratories. And why there is a difference. Now, it's a very, very subjective matter, company policy, pricing, right? One of our panelists is CFO, so he must be well aware how it has to be designed and because I personally has designed it. So it's a very, very subjective piece. But then these are the basic expectations. And in that also there are multiple anxiety, curiosity or apprehensions are there with the patients. But what are still expected, which are not being unmet and which are not being unsaid also. And which clearly brings in the retentivity and repeatability of the patient in the network. Any company, any, not just the pathology, but even in the IVF or maybe in the any area, repeatability or retentivity of the patient or the consumer is a healthy sign of a business going into the right direction. It reduces out the overall operational cost because you have already acquired that customer. The cost of acquisition has already incurred. He is retained, he is loyal. So those retentability and retentivity comes out of basic issue is the wait time. In any area, in any service, including me, I can't wait. If at all I'm going to buy out something at a departmental store and if I have to wait for 10 minutes, I probably will divert my route to somebody else, get me finish that and let me come back again once the counter is free. So wait time engagement. Now what is happening? This now will fall into the domain of patient experience. Today, everybody, entire healthcare is working towards the patient experience, how to increase the overall experience of a patient. But what exactly is happening? The best part is, yes, we all have started thinking globally. But acting it locally is yet to be executed. Wherein what is the patient's need in a category B town versus what is the need of a patient in the metro city. And that's where we have to do interventions to keep them engaged, to reduce their wait time. Obviously, there are certain times, like in radiology, there cannot be reduction of the wait time. One has to, but how can we engage them? So that is very important. So that is one of the unmet piece or maybe unsaid even, and which may sometime turn out to be the very chaotic also. Second is something, I should say that 24/7 helpline number or the dedicated person. Because today, if any patient going to give out the blood, for them the phlebotomist is the company or the doctor or the savior. For them, if he or she knows only that phlebotomist whom one has given out the blood for. Now, likewise, once the blood is given out, then they should have somebody at an back end whom they can really connect to 24/7. There are multiple reasons, not from the B2B perspective, even with the patient's perspective. Sometimes even patients may want to add, edit test or delete test. Or sometimes maybe there may be another reason for which they want to get into touch with the laboratory or any of the healthcare partner or the service provider. So there is a requirement of a 24/7 helpline number manned by well-educated and trained personnel, not just as in call center executives. Because we are not dealing into selling of any insurance scheme or credit cards, it's all about the health of a patient. Can be illness, can be wellness. And yes, thirdly, which I personally have come across is the value-added services. Today, most of the path labs having lakhs of database on multiple disease or the ailments, which can be segregated and there can be a customized program can be created, be it is around the diabetic or the neuro or maybe the cardio, around any areas, and then can be propelled all out with the multiple interventions. It can be shaken hand with the multiple NGOs and so on and so forth. So these are something, and because all these pieces are very, very important in the remote areas where they are devoid of kind of best of the healthcare service providers. They are fully dependent on one or two nursing homes, which itself need lots of grooming and training to get onto the level at which any metro hospital or nursing home is at. So these kind of value-added services, not just like putting up a yoga teacher into the center or diagnostic chain or maybe letting sit in the dietitian, right, giving out the diet counseling. It's just kind of a wait time engagement, I should say. But value-added services wherein if I have a database of a lakh patients who are like diabetic, can there be any program which can be figured out? And yes, there are multiple interventions are happening at global level also, and hopefully soon there'll be this kind of in India also it is there. So many people I am knowing who are doing this, but in coming times it will be even more. Thank you.
So Dr. Arunkumar, I think as far as radiology goes, I think it uses both data and advanced analytics and AI a lot. So can you just throw some of the light on how is AI and advanced analytics being used in radiology, which also helps in the patient centricity and some experience that we give to the patients?
Which I'm very comfortable answering. So as a radiologist, until 3-4 years back, I used to ridicule AI technology, like how can a computer or software report scan, because I'm used to spending and scrolling through the 1,000 set of images and then forming a report and typing it up. But one fine day, I uploaded a CT brain in one of the in a company called Cure's CT brain reporting portal, and it gave a beautiful report. There was it was like in just 2 minutes, I got a report for CT brain, whether the patient had fracture, whether they had an infarct, or whether they had an hemorrhage. These three things were even available, I think, 3 years back. Now they've developed a lot after that. So that day, I decided we as a group should have a definite exposure in AI. So we started engaging with most of the radiology AI companies. At present, we have fully implemented X-ray chest solution, CT brain, MRI brain, as well as a MRI spine solution. So we have AI for all those stuff now. So the one which is more meaningful, which I very, very like, is the CT brain AI solution from Cure. So the patient gets scanned. The patient comes for stroke or injury. So he gets scanned. And before he gets out of the gantry, this is the MRI or CT machine, and comes out of the room, the preliminary report is ready from the artificial intelligence system. And it is directly sent to the referring physician, the one who sent the patient with the head trauma or stroke. The one who actually needs to take a decision on it, it's automatically sent to the physician also. So a CT brain report in 5 minutes. So it has there is a concept called symptom to treatment time in stroke. So the patient suffers a stroke, has an hemiplegia, and the minute he starts developing the symptom, the brain tissue death starts happening, especially since brain is a very important organ. Each minute, I think it's around 1 cubic millimeter of brain is affected for every 3 minutes of delay. So every 3 minutes, there is 1 cubic millimeter of brain which is slowly undergoing death. So the treatment, which is thrombolysis, needs to be decided as quick as possible and needs to be administered more faster. So if you get a CT brain report in 5 minutes, that's like astonishing thing, because before it used to take at least 3 hours for a CT brain report. 3 hours, you multiply it by the cubic millimeter thing, and most of the infarcted area goes for death before 3 hours. So we initially deployed the CT brain solution in a remote place called Tenkasi, which is close to my hometown. So we initially deployed there. There is only one radiologist for the entire district. It's a place in Tamil Nadu. So there is only one CT reporting radiologist for the entire district. And there is only one CT which caters to the entire district of 25 lakh people. And there is no neurologist and neurosurgeon for the entire district. So it was a very highly impactful study which we did along with the AI company. And what we found was it reduced previously the symptom to treatment time in Tenkasi for stroke used to be around 5 hours. The patient will present with the hemiplegia, he'll go to the doctor, then the doctor refers the case to us, we do the scanning. Post-scan, our radiologist, at the most, he can report in 1 hour. Sometimes it will be 2 hours. If the patient comes at midnight, it will take morning 10 a.m. for the report. Until then, the patient nor the doctor doesn't know how to do, what to do with the patient, which treatment to give. Post implementation of AI, we were able to give a preliminary report in 5 minutes, and it reduced the symptom to treatment time to close to 2 hours. From what was 7 hours or 6 hours earlier, it came to 2 hours. So that was a very high, AI has a very good impact in CT brain. So as far as chest X-ray is considered, it's more of don't miss an anomaly in chest X-ray, don't miss abnormality in chest X-ray. Chest X-ray is very notorious in the fact that small fractures, small nodules, or tiny pneumothoraces, they get missed often by radiologists, because the number of chest X-rays we do is close to 700 X-rays we do per day. And for a few radiologists who are going through the chest X-rays, they need to be very sure. And it's a small modality. They report it in 2-3 minutes. So there is a high chances they may miss a small anomaly. And the chest X-ray algorithm which we deployed, it helped us in, initially we did a study of 400 cases. And we found that AI detected 3 small nodules and 2 fractures and 1 pneumothorax, which was missed by our own radiologist. This was a post-analytical thing. So, but AI also missed around 50, 60 abnormalities, which our radiologists also found. So now we've deployed a platform where both AI initially does a preliminary reporting, which is not released to the patient. Then radiologist does the final reporting after seeing the AI findings. So we can be now 99.99% sure that no findings are missed in chest X-ray. It has brought down the TAT also for chest X-ray because the radiologists are more comfortable reporting X-rays. So similar things are happening in MRI brain and MRI spine as well. So the kind of impact AI is going to have in the next 2 to 3 years will be very, very big.
Thanks, doctor. And I think, from some of the anecdotes that I have heard, even radiologists are becoming very comfortable using AI now. And for them, it's more important is like, if they don't find anything on that image, they spend more time trying to find something because nothing is there. So there where the AI really helps. If like AI can actually detect something, their time of, searching, like searching, finding Nemo in that ocean goes down.
Actually true, yeah. That is what main feedback from a radiologist. The time to report normals has come down. Before the radiologist reports a normal chest X-ray, he used to view the X-ray 3 or 5 times, sometimes even 6 times before reporting a normal. Now if AI says it as normal and in one view they are seeing it as normal, they report it as normal.
Yeah. Moving over to you, Vish, I think, like both as MFine and as a person, you're very passionate about technology. And we hear a lot of things happening on this NDHM and, the different ideas being created. How do you see this, technology and especially the National Digital Health Mission, etc., contributing in changing the patient centricity and how the labs will evolve over the next couple of years?
Yeah, this is a very interesting and evolving
You're on
area.
mute, I guess.
No, I'm not on mute. I'm audible now.
Yeah.
Yeah. So I think this is one of the most exciting phase I'm seeing. ABHA has been created. Government has been distributing it across the portals. There are two ways to look at it. One is from a patient perspective, from a very clinical perspective. A doctor needs to know a clinical history of a patient. And today, a patient history depends. If it's fever, it's a three-day old data. If it's some congenial thing, it's lifelong. And the patient forgets over the age what he had been going through, and because he has to go on, keep on repeating the same thing, and I think he forgets what, and he misses something about his medication, blah blah blah. And second thing is we don't store our health records, X-rays, past CT, all that data anywhere. Now with ABHA coming and with all this data getting stored in a central place, one can only see that. And if this data is made available anonymized basis to organizations like all the labs here, I think their way of reporting health outcomes will be very, very different than what we see today, which is based on the immediate outcome. Now, for example, if somebody has access to a previous CT of the same patient, then the outcome reporting will be very different than what we are trying to do today, because it's not event based. Now there's a longitudinal data available. I think ABHA, and second thing, it's going to create huge amount of access and making, like Tenkasi is one example Dr. Arun told. I think those kind of examples you'll see from Kohima to, I think, from to Kargil, etc. So once ABHA data repository happens, I see there'll be more startups coming or ideas will come where how do we use the anonymized data to make it more rich and build those hypergraphs and data analytics. Praxis, you will be the kind of interpretations you do in radiology. I think pathology also will start having that kind of interpretations. Today, we don't have the AI-based significant interpretations in case studies that is in pathology. I think that's what I believe will happen when this whole thing gets evolved over a period of time. Next 3 to 5 years will be very exciting times.
Thanks, Vish. And I think since we are running out of time, is there any question? Because if we have the benefit of esteemed panelists with us, if our audience has any question, so we can take 1 or 2 questions, or otherwise I'll just ask any questions. Okay. In case there's no question, I will just, yeah, sorry.
I was checking the use of AI and what is, so that guy, Pavilion, he said that he is handling this oncology for last 20 years. He has seen a role of AI quite successful in case of what you said, like X-ray, chest X-rays and all. But when it comes to detecting in the brain oncology space, he's saying a lot of role yet to be played because the kind of scans that you need is way more and way more longitudinal and latitudinal before you really arrive. So just wanted to know your view. Do you really see that role in the brain cancers also very successful and supplementing the radiologist on that?
Thank you, sir. As far as onco brain MRs go, there's two things. One is detection of abnormality, the detection of neoplasm. The other one is diagnosis of the neoplasm. So as far as detection goes, detection is basically finding that there is a large lesion in the cerebrum or cerebellum, and there is edema around it. What is the size of the lesion? These kind of detections already can do. There is a neoplasm. It can say there is a mass there. It can be neoplasm or infection with surrounding edema causing so and so midline shift and needs emergency treatment or not. It can immediately say. The AI can immediately say in just 5 minutes. But as far as diagnosis go, that is classifying whether a mass is a neoplasm, whether it's an infection or demyelination, and what type of neoplasm it is. It can be what grade it is. That AI still has not found its way into. That still requires intellect from the human radiologist to bring into it. And as far as I see, I don't think AI will come in the next 5 years or so to diagnosing what is the exact condition that a patient has. As far as treatment is considered, nowadays AI is playing a large role in neoplasm treatment, diagnosing which IBM Watson can actually, with a few algorithms, it can actually tell for a grade 2 gangliocytoma in cerebrum, it can exactly tell which kind of drugs for that exact patient you need to choose based on his history, based on his imaging, based on his genetical profile. It can next-gen sequencing of the tumor tissue. It can exactly tell which drug to treat the patient to get the most efficient treatment. So detection and treatment is at present still playing a role. In the future, diagnosis part will also come into AI's view.
Thank you, doctor. Any other question?
That is kind of impacting the pricing of pathology test and to certain extent radiology tests as well. So do you see these trends are sustainable, or do you see that eventually people will have to go to the rational pricing of the pathology test as well as the imaging test?
That's a fantastically good question. And the simple answer to that is that, there are, of course, a lot of players in the market. And a basic difference, and you can really quickly categorize them in two baskets, that are they out there to create valuation, or are they out there to create a value? and therein lies your answer.
I think well answered. Okay, the last question, please.
Giving me this opportunity to ask a question. I am Dr. Dikshit, and also I would like to address this elephant in the room, AI. How AI is just changing healthcare. So my question is to Dr. Arunkumar. How do you think AI will repurpose the work of radiologist? Thank you.
So I think it was a conference at Google I/O 2008. Some senior ML specialist told that AI will replace radiologists, and that is the most quoted article in radiology AI in the last 15 years, and that is what brought fear into the minds of a radiologist whenever AI as a subject is brought in. AI will replace radiologists. That is the exact quote and the exact name of the article he mentioned. So it's not so. As I said in chest X-ray, AI plus radiologist will improve. AI will find a few missed nodules and fractures, and which are missed by the radiologist, and radiologist will find a huge number of missed nodules and fractures which are missed by the AI algorithm. AI algorithms are not perfect. Radiologists are also not perfect. And when the man and AI comes together, man and machine coming together, I think will be the future. So it has been repurposed now. The article name has been repurposed now as radiologists who use AI will replace radiologists who will not use AI, who do not use AI. So I think that will be the future.
I think, thank you, Dr. Arunkumar. I think on that note, we'll close this session. I think thank you each of the panelists for lovely inputs. And it was a great, insightful session. Thank you so much.
Thank
Thanks.
you.
Thanks,
Thank you,
Vish.
Sumit. Thank you, my co-panelist. I thoroughly
Thanks.
enjoyed being here.
Thanks, Sumit. Thanks, everybody. Thank you. Thanks, doctor. Thanks.
Thank you.
Thank you
Thank
to
you, Vish. Bye-bye.
our guest speakers. And I would also like to thank Mr. Sumit Goel for so expertly leading this session. I request Dr. Kunal Dhamesha to please felicitate Mr. Mitesh Dave. Next, I request Dr. Sonia Gupta to please felicitate Dr. Sarjana Dutt. Dr. Sonia, if she's not there, I request Dr. Naveen Nishchal to please felicitate Dr. Sarjana Dutt. I request Nidhi Goel to please felicitate Sumit Goel. I request Pallavi Jain to please felicitate Dr. Arunkumar Govindarajan. Thank you so much. I request all our guest speakers to please resume their seats. Thank you.